CTSC Distinguished Speaker Series. And go ahead, Dr. McCumsey.
Yeah, hi everyone. It's my honor actually to welcome Dr. Enders, who has a long bio sketch, but to tell you in short, she's a professor of biostatistics and professor of clinical and translational science at Mayo Clinic. She's a consultant statistician. She has more than 200 publications, H index of 65, and a lot of citations. She's the Associate Dean for Academic Affairs in the Mayo Clinic Graduate School of Biomedical Sciences. She's the Associate Director of the Mayo Clinic Center for Clinical and Translational Science, and MPI for the Center for Chronic Disease Reduction and Engagement Promotion across Minnesota. Dr. Enders is highly regarded nationally for her paradigm-shifting leadership on the science of science in 3 areas. First, hidden curriculum for research. Second, health outcome and population engineering or HOPE. And the third, population-conscious analysis. Dr. Enders currently serves as a member of the advisory committee for the Encoding Equity Alliance through the Council of Medical Specialty Societies. She's an elected fellow in the American Statistical Association, and she's the president-elect for ACTS, the Association for Clinical and Translational Science. So Dr. Enders, looking forward to your talk. Thank you for joining us today.
Thank you so much. It is an honor to be here. I'm going to be talking about optimizing hope, and I will explain what that means as we go. As we go through, you'll notice first, no disclosures, but if you see a purple star on the screen, that means you might want to snap a photo of it. So just as background, this is now history. Medical research really is continually adding tools for populations that are included in research. And you can think of each study that we do as a tool. And yet there are some groups who historically were marginalized where we don't know which tools will work for those populations. And equitable research actually would not rectify the situation by itself because those trees are so small. Because of that, many folks in clinical and translational science had been focusing on research in special populations, but that is no longer prioritized at the federal level. And so we're left wondering what to do. So I'm going to switch gears. Instead of trees, now we have arrows where equal healthcare at the top is a basic human right. And some groups are not really, we're not prepared to bring equal healthcare. We could think of this for these different populations using whatever metrics we wanted to determine who was in which arrow as the need for differential benefit, where we want to bring everyone up to equal healthcare. But group level research is really not prioritized at the moment. So we need something different. And that's what I'm going to talk about today. Individualized differential benefit does everything at the level of the person. And this is actually critically important because you'll notice over here in this group where the group as a whole didn't need as much help to reach equal healthcare, there were some folks who did need more help. And then in other populations, this is a population where most people need help, but some people don't. And so individualized differential benefit takes us from group level metrics to individual metrics where we're including everyone, helping everyone, and differentially helping those who need help the most. So the background for this work, though, is that in research, the way we use demographics, they're really a proxy for many other things. And I'll get more detailed about this at the very end of the presentation. But I want to talk about this big picture now. The history of this part of the talk comes from many, many decades ago now, or at least several decades ago, when I was a teenager. I was my mother's primary caregiver, and she had a number of chronic health conditions, and it was just the two of us. And I remember one time we were at an emergency room, and it was not our usual emergency room, so no one knew us. And I overheard the resident dictating, African American woman, claims to be age 50, appears closer to 80. Now, that was my introduction to accelerated aging. And those same groups who had lower arrows, smaller trees, who were less likely to achieve equal health care, are also at risk of chronic stress at the individual level, and high chronic stress can yield accelerated aging. Now, let's talk about that idea that demographics are partly a proxy. And we're going to talk about this in a variety of areas. And very quickly, I apologize because I have a lot to bring to you today. So Francis Collins in 2004 wrote about how demographics were partly a proxy for genetic ancestry, but also for social and structural factors. When we think of structural factors, one really big one is where we live. And if we are lucky enough to own a home, that might yield generational wealth that could get passed to our family. But if we own a home at the local level, property taxes are what fund our public school system. And then lifetime education is a really strong predictor of both lifetime wealth and lifetime health. So that generational wealth in part is built on the structure of the map of where we live, and that map has history embedded within it. And there's many other examples of social and structural issues. Clinical calculators, we have a number of clinical calculators that use demographics within them. An example here is the estimated glomerular filtration rate, which was used to estimate kidney function using race as one of the predictor variables. The calculator has since been changed, and the reason it was changed was that EGFR was then being used to help as one of numerous factors to decide who had access to kidney transplant, which meant that for some people, access was modified because of their race. But changing a clinical calculator is a lot of work. And so it would be great to not put it in at all. And we will talk about that later today. But accelerated aging was where I started with the piece of the talk about my mother. And accelerated aging, we now have something of an understanding that chronic high stress, not stress that goes up and down, but stress that stays at a high level, can yield aging at the biological level. Within our cells, on our DNA, the telomere cap at the end of the DNA gets shorter as we age, and it can get shorter faster if we are aging too quickly or faster than our years would suggest. But also the wrapping around the DNA, the methylation, changes shape, and there are now calculators for biological age based on methylation. And mitochondrial function and inflammation and numerous organ functions can be aligned with our biological age, which may be different from our chronological age. And when we see that at the level of the person physically looks older, which was what the resident had noticed with my mother. That's called weathering. That idea of accelerated aging being partly aligned with demographics, and in some ways, demographics can be a proxy for accelerated aging, will be the genesis of both of our little mini talks today. And in this first one, we're going to take that and expand it for an idea of individualized differential benefit within healthcare. And this is where the word hope came from in our title. Hope is health outcome and population engineering. It was originally published as health equity engineering, and that title has had to change. But within healthcare, we can use this idea of accelerated aging to flip things around and change the story. So we had the idea that accelerated aging from stress could yield weathering. In hope, we take that risk of high stress and risk of accelerated aging to identify people for treatment within a clinic. So let's imagine healthcare with hope as a starting point. Alex is a 52-year-old patient. Here, Alex happens to have an underrepresented race or ethnicity. And Alex gets a screening for hope that has nothing about demographics in it. It's all about chronic stress, maybe some aspects of actual accelerated aging. But this screening happens before Alex is even in the doctor's office. Alex has risk of accelerated aging because there are big stressors that Alex lives under, including where they live. And then we have testing for how Alex is doing physically that would not have happened without this screening. As a result of that testing, there are opportunities for intervention because we're identifying things before they would otherwise be found. And that intervention lifts Alex up to the point of equal health care. Now, there are many benefits of hope at all levels. For the patient, earlier disease detection gives opportunities for intervention. For the provider, it's not just getting to talk to Alex and help Alex. There's also the use of different diagnostic tools, which gives justification for further testing. And we don't talk about this very much, but providers do have to pay for their time. And that also gives additional actual minutes of time with Alex. And that is really beneficial in today's setting. At the level of the payer, because we are looking at earlier prevention, primary prevention, we have reduced treatment costs. And at the level of society, we see reduced morbidity and maybe even delayed mortality. So how do we get to that point where primary prevention is deeply embedded within our healthcare system? Well, there's a number of steps. First, we need to develop a bunch of tools, both to identify people who are at risk of accelerated aging and intervene. And those sets of tools we can actually work on simultaneously, and there are a number of things that we can use already today. We can place tools within our clinical systems after we have them to make them easy to use. And to identify patients, one thing to do is to screen or survey people for chronic stress. An ideal survey, in order to be used at the point of care, has to be really short and cover the life course and use general questions, meaning not focused on stresses of a particular topic, because we don't know what sources of stress Alex may actually happen to have. Now, in our review, we did not find an ideal survey, and we're working on that. And I'll tell you about that in a moment, but we do have two things that are really good that are usually already in place within the healthcare system. The Adverse Childhood Experiences Scale covers childhood and uses very specific questions, but it's fast and it is strongly associated with chronic conditions. And then socioeconomic status by itself is a huge predictor. There are other things that I will get to on the research side of this later in the talk. Another thing we can use, though, that's a very different approach is to look at geocodes based on the home address. A geocode is looking at that map of where you live. Here's where you live, and here are the stressors that you're exposed to based on where you live. And we have people's home address in the electronic health record. Using that, we can get to geocoded tools such as the Area Deprivation Index or the Social Vulnerability Index or houses. There's the multimodal measure of structural racism. And this is really an area of exploding research. Virtually every time I look, there are more different geocodes available because there are so many things we can learn about what a person is exposed to based on where they live. Now, we can also take a totally different approach and assess biological age. Now, neither of these approaches is perfect today, but there is also an explosion of research happening here. So around our DNA, I talked before about telomere length at the end of the DNA that gets shorter as we age, and methylation that wraps around the DNA, and we have methylation-based biological clocks. These are both things that I worry about using at the point of care, though, because they're expensive and slow. And if we focus in on tools that require a fair amount of resources, then we increase disparity rather than decreasing it. Another approach is to use allostatic load. Now, this is one approach for allostatic load that uses things like systolic blood pressure, diastolic blood pressure, heart rate, and so on, that we would see in the clinic. And this particular one was derived from Dean et al. There are many different approaches to allostatic load, but basically we're looking across body systems for the accumulation of chronic disease. And that is a really important driver that we don't take as thoroughly as we ought to, perhaps, in the primary care setting, in part because of time. So individualized differential benefit really is a superpower that lets us find ways to help people, but the tools to identify people are not what actually make us superheroes. It's the tools to intervene and improve health that are most of interest here. So ways to intervene for that potential accelerated aging include behavioral methods. So fasting and exercise both are really fantastic ways to help with accelerated aging. There's also solid research for both nutrition and especially sleep. Fasting, though, is probably the strongest thing within here. However, for any behavioral tool, we're really talking about a conversation between a provider and a patient. And as I started giving this talk to providers, people said, wait a minute, I'm going to need help with that discussion. And that is right on target. If this discussion is not done with the right nuance and thought, it can be more challenging rather than helpful. So it's really important for a provider to acknowledge that the patient has structural factors around them that they don't have control over. And yet, even in the context of those structural factors, the patient has power and the provider is there to help. And then begin talking about things that could be done and discuss realistically what's reasonable for the patient. But in addition to these behavioral things, there's also new biological tools that we can begin to use. These include senolytic drugs and induced autophagy. Autophagy is turnover within the cells, and that can be quite beneficial. Once we have these tools, though, for screening and intervening, we need to embed them within our EHR so that this becomes seamless for providers because providers don't have a lot of time. And we need to have as much as possible happening behind the scenes automatically. So I mentioned before when I was talking about screening that we didn't find a perfect tool in our review of the literature. So I started about making one, and the first one I tried was this. It was based on the idea of pack years in smoking, where we would have discrimination per year times years of discrimination, giving the life course experience of discrimination. Now, this tool worked really well. It was very fast, and it correlated with a number of things that we expected it to correlate with. Race, ethnicity, but also sexual and gender minorities, intersectionality, having more different identities that are from underrepresented areas, the Fitzpatrick skin phototype, which is basically depth of skin tone, the everyday and major experiences of discrimination scales, and the adverse childhood experiences scale. However, I've never published this because I felt it didn't work at all. It was only capturing interpersonal discrimination. That misses structural discrimination, which isn't, you might not even use the word discrimination because it's not intentional, right? But also, the concept applies for all stress, not just discrimination. And some of the responses that people gave really highlighted that. So I went back to the drawing board. This version, the Evaluating Life Course Stress Experience Scale, is again based on pack years in smoking, stress per year times years of stress. It's a very general question, and people are answering for every age range in which they have lived to date, their recollection of their overall average stress level within that age range between none all the way up to very severe. And then that is essentially averaged out across their life to date. Now, the results of this we looked at this against total adverse experiences and found that 16% of else that experiences of life course stress can be predicted just by knowing total adverse experiences. And that was actually true across different age ranges, which I didn't really expect to see because the numbers were so much smaller. It also was predictive of early onset of dementia. And I'm not showing that part, but that paper is under development. But the reference that I'm showing a QR code to on screen is the initial paper about health outcome and population engineering, which again was published under the term health equity engineering. So that was, again, this idea of demographics are a proxy, and we can use individualized differential benefit focusing on accelerated aging to flip the storyline in healthcare at the individual level. That was in healthcare. Now we're going to switch and look at, again, following up on the idea of demographics as a proxy, but this time in science. So this is an idea called population conscious analysis. And it's really changing how we do all of our analyses across all of science in terms of how we treat demographics. And I will start with race ethnicity because that's how I came to this idea. And then I will generalize it at the end for what I'm calling social demographics. So race ethnicity is not a biological variable. But as a statistician, I found that I was regularly including it in analyses as a predictor variable, and it was statistically significant a lot of the time. So the question was, what was going on? And this was something I came to long after I was at full professor, after I'd done a lot of papers that include this mistake. And I think it's tough for us to change as a field, and yet I think it's really vitally important that we do. And you'll see why. So we talked about this idea, race, ethnicity, and other demographics act as partly as proxies, and that idea that they're acting as a proxy for all these other things has not yet been incorporated into our scientific methods. I talked about clinical calculators and estimated glomerular filtration rate. That's an example of why this is a problem. So when we put race ethnicity in as a predictor variable, like we did with EGFR, and it becomes important and published, and then it goes into a guideline, and then it's out there in clinical care, and we have a clinical calculator that uses race ethnicity. What it's doing is embedding structural racism into clinical practice. That is a huge problem. The National Academies of Science, Engineering, and Medicine came out with a report on rethinking race and ethnicity in biomedical research that talks about 4 different categories of research. And they were looking at this very broadly, not just for that one problem of embedding racism within clinical practice, but across all of the research that we do. And they came up with these 4 broad buckets. I'm going to talk through the buckets first and then go back to what I think we should do instead. So race-based research is incorporating race as though it were biological, but it's not biological, so that's a mistake. Race-neutral research leaves race out completely. Now, if we're not supposed to be doing race-based research, this seems like the next logical thing to do. This was actually where I was about a year ago or so, 2 years ago. And then I realized, I didn't realize, I read the NASM report and thought, they're right, this is a mistake also. So you can think of this as being like someone saying, I don't see color. People of color don't have the option of not seeing color. So race-neutral research is also a mistake. Then they had 2 good categories, Race-conscious research is designing studies, policies, or interventions that are really looking at things that are specifically aligned with race that can impact health. That's really good. And then racism-conscious research is looking at various forms of racism and structural drivers of health contributing to health disparities. The concern I had as I got deep into this National Academy's report was that I felt like there was something missing because these two good categories of research are focused on research that is about either race or racism. And most of the research we do in biomedical science is not about either race or racism. We just want to use the race variable without making the mistakes of either race-based or race-neutral research. So that's the background, but I'm going to talk next about what we typically do in science just to set the stage. So this is our operating procedure for science, where we sample by race ethnicity. This is typically table 1, and we assess inclusion by race ethnicity. And then we develop our model using race ethnicity as a predictor variable. Now remember, this is where we get into trouble because we put it in as a predictor variable, it gets published, it goes into guidelines, it gets used in clinical practice, and suddenly we have race influencing clinical practice and thereby embedding racism into clinical practice, all completely unintentionally. So we should not do this. And we typically fail to interpret the race ethnicity variable, which means that according to the NASM report, this is being usually implicitly understood as ancestry by the reader. And that means that we're really by default doing what the NASM report would call race-based research. So we're frequently doing race-based research. We want to use the race variable because it's clearly showing things that are important, because it's statistically significant, and that's the whole meaning of life. Just kidding. But we don't want to do either race-based or race-neutral research. And we're typically not doing research that's focused specifically on either race or racism. So we need a whole new category here. I propose that what we need is something that I started by calling race-conscious research, but I'm now calling population-conscious research because this is actually much bigger than race, and we'll get there near the end. Population-conscious analysis is a new method of analysis that uses things we already know how to do, so don't get scared, but it's a way to avoid both race-based and race-neutral research when race is not the focus of the research. I'm going to talk us through first the components of population conscious analysis. Now, remember, in the idea of individualized differential benefit, we want to look at things that are at the individual level rather than things at the group level. And race is a group demographic level, and that's part of the reason it's so rough, if you will. And so we want to come up with new individual level variables to include in research that might help us to replace the race ethnicity variable. And that's the first step of population conscious analysis. So in thinking about what variables to collect, I want to start by thinking about what data we might collect in our study. So when there are biological samples, we would want to look at the gene of interest, but also any biological markers of aging, stress, or chronic disease. When the study is prospective, we might have a clinic visit or a survey. If there's a clinic visit, we can look at allostatic load. When there's a survey, we can look at social drivers of health or stress or chronic disease. Now, that was all when the study was prospective, but if it's retrospective, we could look at electronic health record or registry data that's aligned with chronic stress. But that's available not just for retrospective studies, but also for prospective studies. So we should really always use that. And before I go on, first, we want to look at all possible variables we can think of for any given study, because the first few variables we look at are probably not going to work. This is a new idea. So we want to have a number of options for each study. And then across the bottom of the screen, you'll notice we have A, B, C, and D. I'm about to expand those into actual variables. And here we go. So these are actual alternative variables, and I will begin and expand across the screen, and you'll see the pink star when it's at a point where you should probably think about taking a photo, because I want to give you actionable things to actually use right away. Here we have, if you have biological samples from patients, this was category A on the previous screen. This is going to give us things that are more invasive and more expensive, but also more precise. And then as we go across, we will get to things that are less invasive, less expensive, but also less precise. But here under biological markers, we have the telomere length, that's the cap at the end of the DNA, methylation-based biological age, the wrapper around the DNA, cellular senescence and mitochondrial function. But we could also look at cortisol from the last few months that we could get from fingernails or hair. That's the level of how much stress we've experienced. Or kidney function or liver function might be good to think about here. I want to point out also that the ones in italics are the ones that I consider too expensive to use when we're planning to create something for use in clinical care. Because anything that we develop for use in clinical care, we want to have be accessible in all clinical settings. Next up, we have allostatic load. Now, I gave you a long version of allostatic load before. This is a 5-item version of allostatic load from a paper that looked across a whole bunch of different types of allostatic load to come up with a consensus definition. And this was very predictive of, I think it was cardiovascular disease. I do have one addendum to this, though, which is that this uses waist to hip ratio. And as I've been giving these talks, I find that I'm becoming, I don't know what the word is, but people keep bringing me new things. And so I've learned that there's new research coming showing that waist circumference is actually much stronger than waist to hip ratio. So this is my personal version, my favorite version of allostatic load. It uses CRP, C-reactive protein, is a measure of inflammation in the body. Resting heart rate, which is really strong predictor of how well you're functioning, and is also aligned with cardiovascular health and obesity. HbA1c is a measure of how we're processing sugar, HDL cholesterol, and then waist circumference. And so we're looking across different body systems, but these things are all strongly aligned with increasing challenges across the body. And let's see, I'm going to keep going in the interest of time. If we talk about surveys, here we would think about innumerable surveys. There's just a few that I'm going to call out, and I'm going to give you a few references here as well. So the chronic burden scale is a pretty good, fast measure of stress. I had said earlier that there's no perfect measure, but this one is actually pretty close. It's just not in use as much as I would like to see in research. The first reference is the one to cite. The second reference has a wonderful description in the method section about how to actually use this chronic burden scale, both for asking the questions and then using in the research. Adverse childhood experiences scale, I think most people know. The American Heart Association has Life's Essential 8. It may move to the necessary 9 soon. I think that's about maybe well-being. But for Life's Essential 8, a key question is how to get at the 8 different measures, 4 of which are biological, but then 4 of which are behavioral. The American Heart Association does have their own way of addressing this. I've looked at this within the Health Excellence Action Network, and the 4 biological items are the same, but down at the bottom, the behavioral scales, we went with things that were very short and did not include cultural bias. Then, sorry, let me finish out here. Everyday discrimination scale can be helpful because it is a good marker of discrimination across different categories and demographics of folks. The life stressors checklist is very specific and very long, but also strongly correlated. And then I spoke earlier about the exposure to life course stress experiences scale, which is the one based on the idea of pack years. Okay. And then finally, for any type of data, we may have access to electronic health record or registry data. One of those would be geocoded measures of deprivation. I've mentioned a couple times that where we live gives access to what stressors we're exposed to around where we live. In order to turn the home address into a geocode, the CDC has developed a tool that lets you do that, where you can even have a participant go in, put in their home address, and get their 15-digit GeoID directly from the site. Or you can look at these in aggregate, putting in a batch of home addresses and turning them into geocodes. So if you think about using this, please do take a screenshot, because without this tool, it's much harder to get access to how this works. Then we have health system measures like insurance and comorbidity scores. How many different diseases and conditions has the person accumulated? So this is my set of alternative variables, but I really think of this as a starter pack, if you will, because I anticipate that we're going to keep learning about how to do this, and there may be numerous other things that should be on here that we have not yet identified. So for population conscious analysis, we want to do analysis that uses the race variable without having race be the focus of the analysis. And our first step is to replace race ethnicity with a whole set of other variables from that starter pack. But that takes us from race-based research to race-neutral research. We need another step to go to population conscious analysis. That step is called assessing residual confounding. So first, I'm going to define what that is. Confounding is when we're looking at the association between X, a predictor, and Y, an outcome. And there's another variable, this extraneous factor, C, that happens to be both a risk factor for the outcome and it's associated with the exposure X, and it's not in between X and Y. If we ignore the confounder, and we're doing observational research, the confounder does not go away. Instead, its effect changes what we see as the effect between X and Y. Instead, we can model them both together. Usually this is why we wind up using regression so much. And we add the confounder as another predictor, and we can see their separate effects. But that was defining confounding, and what I talked about was residual confounding. The word residual is a quantity remaining after other things have been subtracted or allowed for. But residual confounding, by the Dictionary of Epidemiology, is potential confounding by factors that have not yet been considered in the analysis. Now, we're going to use this idea somewhat differently to intentionally assess race ethnicity as a potential latent residual confounder. Really, what that means is we're going to see if there's evidence of other factors that are still associated with race ethnicity, even in the context of the model that we already have. So now, population conscious analysis, we will first replace race ethnicity with other variables, then we'll assess residual confounding by the demographic of interest, in this case, race ethnicity. And I'm going to walk us through that first with a revised standard operating procedure, and then with an example. So in our revised standardized operating procedure, the first two steps are the same. We're still sampling by race ethnicity and assessing inclusion by race ethnicity. Then we are developing a model without using race ethnicity as a predictor variable. This is using our starter pack from before. And in doing this, we're avoiding race-based research. And then we are assessing residual confounding by race ethnicity. This avoids race-neutral research. And when there is statistical significance for race ethnicity in the context of our model from step 3, that gives evidence that there are latent factors still associated with race ethnicity, even after adjusting for the other things in our model. And then we interpret race ethnicity as a proxy to be especially sure that no one thinks we're doing race-based research. So here's an example. This is using life course experience of discrimination, which is a variable that I did not particularly like. I just had some data sitting around. We're going to use that as an outcome variable. And we have 4 different potential predictor variables on screen, none of which is race ethnicity. We have to leave race ethnicity out and replace it with other variables for which it might have otherwise acted as a proxy. And so here we have some gender stuff, some sex stuff, adverse childhood experiences, and major experiences of discrimination. We run an analysis, and 2 of those together are predictive of life course experience of discrimination in this particular data set. By having left out race ethnicity as a potential predictor variable, we have avoided race-based research. But now we ask the question, in what is really a race-neutral analysis right now, within the context of this analysis, where we're already adjusting for ACEs and major experiences of discrimination, after we know about ACEs and major experiences of discrimination, are there other factors associated with race to predict life course experience of discrimination? In order to assess that, we add race ethnicity into this model where we already have ACEs and major experiences of discrimination. And we're doing this intentionally with race ethnicity as a proxy to see if there are things with which it's associated that are predictive. And because we are still using race ethnicity not as a primary predictor and intentionally as a proxy, we are now avoiding race-neutral research. And here, it's statistically significant, which means that there were additional factors associated with race after knowing about ACEs and major experiences of discrimination. And that leads to the question of what does that mean? Really, what it means is our best model still didn't adequately account for issues of race and ethnicity. And more research would really be needed to unpack what those other factors might be, because there's a whole set of things for which race ethnicity might be acting as a proxy. And that research has to be done within the context of this particular model. Now, I developed all of that focusing in on race ethnicity after having read the National Academy's report on race and ethnicity in biomedical research. And yet, after I came up with it, I realized this is really a generalized issue. It's not just for race ethnicity. This is an issue that applies for many demographics when the demographic is acting as a proxy for other variables. This is a term I call a social demographic. A demographic is acting as a proxy. And so here we have a generalized version of population conscious analysis for use with anything that is a social demographic. So I have a list of potential social demographics on screen, but any of them could be a direct contributor or it could be a social demographic depending on the situation in the study. Let's think about language. Imagine that you have a study where you're looking at access to healthcare within a particular healthcare system that does not include translation as an option for patients. In that case, the patient's language is not a proxy. It is a direct driver of health. And in that case, language is not a social demographic, and we should not use population conscious analysis for the language variable. But in a different study where you're looking at health in general and language is not a direct driver in the context of that study, but is instead perhaps a proxy for maybe how the person eats, or maybe social connections, or other factors that are associated with language but not directly aligned, there, the language variable really is a proxy for other things. And when it's a proxy for something else or a potential proxy for other variables and definitely not a direct driver, then we could do a population conscious analysis for the social demographic of language. In a generalized population conscious analysis, we sample by the social demographics, we assess inclusion by them, we leave the social demographics out of our model development in step 3, and then we assess residual confounding for each social demographic variable separately and interpret them as proxies. Now, you can embed some effect modification between social demographics within here as a later point within step 4, maybe step 4B. But that part, I think, you work with a statistician using usual methods. Okay, so we started with the idea that we need to use individualized differential benefit. Demographics really are acting as a proxy, and we can look at that, and we had new ideas, one for healthcare and one for science. Demographics are acting as a proxy, and I really focused in on the accelerated aging component here because the other pieces I feel like are well understood, but accelerated aging we have not accounted for very well in our methods. And that is based on stress leading to weathering. And this concept of differential benefit, we need to not look at the group level for any of our demographics because both that is not necessarily indicative of what an individual person needs, and at the federal level, it's no longer prioritized. But instead, we want to use individualized differential benefit and focus our predictor variables at the individual level and get beyond what we have seen at the group level. This also allows us to hopefully help resolve issues at the group level through working at the individual level. Individualized differential benefit, I feel like is a superpower. I happen to love superheroes, but that's a separate talk. And I have an enormous list of folks who I really want to thank because it's an exciting time and there's so many ideas and people have brought so many things to the table. I'm going to stop there and see what questions we have. Thank you.
Thank you so much, Dr. Enders. That was a great talk. I'm just checking so people can either put their questions in the chat or feel free to unmute and ask your question directly. I see our PI, Dr. McCumsey, said she had to go to an in-person meeting, but she said it was a great talk and thank you for joining us.
She made it until almost the end, I saw. So.
I'm in a car. This is Seema. Felicity, I'm sorry. I'm actually traveling and my kiddos are in the car, but I didn't want to miss this great talk. So I recently actually helped someone with kind of same idea that I excluded race and ethnicity. Just, like you always give me words that it comes to my mind, but I don't have the words for them, like when we talked about the lived experience and, like I knew what I mean, but I just didn't have the language. So you gave me a lot of words and language that I could potentially actually use in this paper. But I need something to reference. So I need your paper or, like I haven't read anything from you, I'm sorry, in the last 12 months, how life has been crazy. So if you have a paper, because I actually received a word from this journal that we resubmitted. And I have to now justify why I actually excluded race and ethnicity. And I had reasons, like I mentioned, but I think that the words that you're using are more, I don't know, like better. I need some reference from you if any of this work has been published.
So the primary paper is currently under review.
Okay.
However, we did have a paper about a year ago that includes the idea that you shouldn't be putting race ethnicity in as a predictor variable. I'm sticking that one in the chat.
Are you talking about the one that we worked together?
Uh-huh.
Okay.
That's in there.
No, not that one. That one, actually, I'm the first author. If you remember, you
Yes, but
guided me.
it says it in the paper. You
Yes.
can reference that.
Yes,
The
I could.
one that I think you want is the one on population conscious analysis. It's
Yes,
been
that
under
that one.
review for
Yes.
more than a month, and
Okay.
I'm really hoping they just take it and you'll
Yeah.
hear about it in the Bird when it comes out, but I don't have it yet.
Okay. Um, I don't know. I just have the submissions are actually kind of soon, so I have to find a way to acknowledge you because of this expression that you're using. Can you say it one more time? Population.
Population conscious analysis.
Yes.
You could reference the keynote presentation from ACTS last year.
Okay, I could do that.
I
Yes.
don't like that because they can't go check it, but
Okay. All right. Thank you so much, Felicity. This was
absolutely.
talk. Oh my gosh. I'm just, like blown away by this amazing work that you're doing. Thank you. Thank you for sharing your knowledge.
Well, I feel like I'm really just a nexus right now because people keep bringing ideas in and it's wonderful. So thank you.
Yeah, thank you.
Total silence. Gotta love that. And, I'm hoping it means you took lots of photos and you're thinking. Um, don't send me an email. I'm terrible at email. However, follow me on LinkedIn and there you can, send in messages or talk with Seema because she knows how to find me.
That's right.
While people are thinking of questions or typing in the chat, I can share a slide here because this session does have CME credit associated with it. I
Excellent.
hope you can see the right version of this.
I think flip it back to the other one.
Yeah, let's see, swap displays here. Okay, hopefully that's correct.
Yes.
Okay, so this will also be emailed to you if you don't have a chance right now to scan this QR code or go to this website. So this is how you would claim CME for this session using the code. And of course, that will, come right after the session to you via email. And then here are two other QR codes. So the one on the left is a way to see all of the upcoming sessions. So next month we have Dr. McShane on March 25th at noon. And then the QR code on the right is to become a member if you are not already of the CTSC to stay up to date with all of our events. Oh, I see. There's a question. How do non-CWRU staff claim CME credits? Oh, we'll also send you, there's an attachment that will come in an email that I believe has the instructions to do so. I will look and I can email you, Amanda. I'll write down your name to see if that does not include non-CWRU. But I believe, yes, it lets you know how in the email. And I see Laura had just put a response in the chat. And I see Rini has her hand raised, so go ahead.
Awesome. Thank you, Dr. Enders, for an awesome talk. I've heard you give a variation of this talk before all the work was done or added onto. So I just wanted to say thank you for bringing so much hope and joy to this space and work and your brilliance. But I wanted to ask you, what brings you hope in this space?
So I actually think individualized differential benefit is something that should have happened in research regardless of issues at the federal level. I think these are ways to help people at the individual level and stop treating people with these giant buckets, which are just too rough. And so I think this is a time when there is so much research happening on many different fronts that's really coming together in places here. Research on accelerated aging at the bench science level, at the behavioral science level, at the measurement level. How do we measure some of this stuff? That makes it a very exciting time to actually make significant change. At the same time, I see some groups that are working very hard to pull race and ethnicity and other demographic variables that are acting as social demographics out of clinical calculators, which is phenomenal and really shows that people are caring about wanting to make a change, and are doing so even right now. It's wonderful. Thank you.
Okay. I am not seeing anything else in the chat, and no other hands raised. So we will end out the session. Thank you so much, Dr. Enders. This was a great talk.
Thank you all. Great to
All right.
see you. Take care.